I got lucky. It's a mitral case. 85-year-old gal in 2002 had a mitral valve replacement with an Edwards bovine pericardial valve, 27 millimeters for posterior flail. Progressive dyspnea, functional class 3, comorbidities as mentioned there, CKD, severe pulmonary hypertension, severe lung disease. By echo, she had prosthetic mitral valve gradient of 15 to 17 on the right-hand side. That's a 3D view of that valve. She had mild MR, EF45, moderate TR, PA pressures in the 80s, and no coronary disease. She has high risk for surgery, like all of our cases that we present, unfortunately, these days. Hopefully that'll change. Here's our CT that we did in preparation for a mitral valve and valve. So the aortomitral angle looks favorable at 129. And the bottom left there, you can see that an S329 valve within that bioprosthetic valve looks good, like a nice fit. The neo-LVOT 285, so nice and generous. And then the relationship between the fossa and the mitral valve, very important here with this horizontal heart. And you can see how the transeptal puncture is going to be incredibly imperative here. So our procedure plan, our focus was really on the transeptal puncture given that fossa mitral valve relationship. We figured an inferior posterior towards a mid fossa stick might be best. We've been using a energized transeptal metal needle, so with the Bovie for most of our cases, but this one in particular to avoid any sliding when we're sticking the septum. You know, we access the LV with an Agilis, pigtail, safari wire like we do for all these cases. We balloon the septum somewhat aggressively with a 14 balloon. I think we've gone down in size on the balloons as we dilate these septums these days, but we use the 14 in preparation for this 29 valve. We also floss the septum a little bit with the partially inflated balloon, trying to make sure that the trajectory felt right and it looked good and felt good and all that stuff. We also use an embolic protection device for this stenotic bioprosthetic valve. That's what's shown on the left here, not terribly relevant for this case. Here's our transeptal puncture just in one view. I should have included the short axis view as well. It looked like we were about 3.5 centimeters away from the valve where our puncture was at this time, so we went ahead and did that. And then we got what I thought was a pretty good looking angle into that LV through the mitral valve. Looks like a nice, easy sort of shot through there. We balloon the mitral valve. We don't always do this. We balloon the septum twice. You see a little waste here and then no waste there. Soon after this, we just did a quick floss through. So all good so far, but this transcatheter heart valve just won't cross this septum. So as I advance up the IVC, the delivery system, everything would just push through the roof towards the roof of the LA. Just could not get this thing coaxial through the valve, despite what was a very pretty picture and a nice trajectory on the wire. So we did multiple maneuvers. We flexed and unflexed the delivery catheter. We clocked and counterclocked posterior, anterior. We tried maximally pulling the delivery sheath back as far as we could safely, so it was less hardware there going through the septum. We tried pulling and providing tension on the wire to give us a nice trajectory into the LV. None of this stuff worked. We then thought to maybe do a buddy or bumper balloon technique. So, you know, we have a transeptal, we have a TVP through the contralateral vein. So we removed that sheath and put in a new one and then put an 8 millimeter balloon through the septum and inflated that to low pressure and then tried advancing the THV through that way. I thought that would work. It didn't. Maybe we got a little bit further with the transcatheter heart valve, but we still couldn't entirely get it through this septum. It was stuck. So then we decided to more aggressively dilate the septum with a Tyshak balloon, 18 millimeter. You can see that looks too big. But we had hit it with a 14, and we just figured we'd go to an 18 at this point. It's not super obvious maybe to this presentation, but this case is frustrating, trying to get this thing through the septum. So we went with a big balloon. Still wouldn't cross. They were stuck at the same spot. This THV just won't go through. So I guess I could open this up to questions or what would people do next, but in the interest of time, I can just roll through this. You prefer that? Sure. Okay. So what next? We've manipulated the delivery system every which way I could think of. We've buddy ballooned or tried to bumper this thing through. We've tried to essentially granuloplasty, just no respect for the septum with an 18 Tyshak balloon. Then we thought, okay, maybe we should externalize. Maybe we could just put a little 4 French in the LV apex, grab that wire, pretty simple. She's a bad lunger, real bad lunger. with an STS of 18. We can also just externalize old-fashioned mitral valve, but I'm not a big fan of that. So what we decided to do was to snare this Safari wire in the LV going through that same transeptal hole that we had already created. And on the right-hand side here, you can see, or on the left, you can see the echo. And on the right-hand side, you can see how we've snared the Safari wire in the LV apex. And then we pushed on that snare device to keep it in the LV apex. And you can see that with this is real time. This is the first approach. It just slipped right through there. Just by that little bit of pinning into the LV apex with that snare, without making a new TA puncture or externalize or anything, it worked just beautifully. We're able to expand this 29 in there quite nicely. We got a little bit of a ventricular placement of this, but it was just fine. The valve looks good. Mitral valve gradient was 3, and there was no PVL. Amazingly, the septum survived this punishment. We just had unidirectional shunting, so we didn't close this. That's our preference, is not to close these things. Thanks very much.
I think that's a great case. I was telling Dr. Goessl here that after that granuloplasty, it didn't matter whether the valve was going to go in, the patient was going to feel better. Because it would just
relieve the LA pressure?
Yeah, relieve the LA pressure.
Corvia would be happy.
Right. And you guys are a great enroller for that. But now thinking about this in advance, this could be something that you could even do in the IVC, right? So you cross in the IVC, have a snare there, make sure it's set up, put all of that into the ventricle, and then go from there.
I really think so. I mean, it takes no time. For whatever and you could maybe even, you can maybe even advance everything through with the snare in place. Maybe that's what you're getting at. Yes, I think that's right.
You made one distinct point where you said you're not a big fan of the transapical access. And when I work with my LVAD surgeons, they always say, why did you not ask for help? Because I could do a 6 French, even 4 French if you want to do it, sheath through the apex with a small incision and really help you out a lot. So,
right.
So what is your argument against that, I
guess?
Well,
we could do it one better. We could put a 4 French there and not make an incision. And you can pull a 4 French out of the apex, usually, and not that I've done it 100 times, and not even close it. Yeah. So, she was a longer. That's the main reason. I don't think she would have tolerated it. This turned out to be, I don't know, would you have preferred that presentation? Probably. I think this is better. I think this is...
Rahul?
What did you push? When you had the snare in the wires, how did you push the tension?
Yes, the catheter that the end snare comes with, that you just use that. Just putting a little tension just to keep that, so you can follow that wire down.
Just to piggyback off the longer comment, it may also be that she has so much hyperinflation of the lungs that the apex may not even be geographically close.
That's a great point. Yeah, we'd have to go back, look at the CT, yeah, great point. Hey.
Excellent, outstanding technique. I had one comment that one thing you can do sometimes that works for us is not to try to advance the entire system, but just push the balloon as if you are going to uncover the balloon, because all mitral valve, that really is the key, that just as soon as you cross the septum, sometimes it doesn't want to turn.
Yeah.
It hits the wall of the prosthetic valve.
Yeah.
So the best thing to do is to just advance the balloon from the back, or extend from the back rather than the entire system.
Yeah, so in addition to pulling the pusher back to advance, I think I hear you. Yep, no, it's good. Mm-hmm.
That sometimes works, and taking out the breath. So in expiration, you hold the ventilation. That also is helpful, because
that's right.
Hurts.
Yeah, we definitely tried to time it with the breathing. Those are great points. Awesome.